the different places of the Philippines. Good morning po sa inyong lahat, and also to our guest speakers. So for this moment, let us first begin our webinar with a prayer. Join me silently in praying. Prayer. Let us begin to pray. Leo, please pakiano pa ng prayer natin. Ayan. Okay, thank you. So in the name of the Father, the Son, of the Holy Spirit. Amen. Almighty God and loving Father, we come to you today with full reverence as we express our gratefulness to your divine presence with us. Lord, we thank you for your unconditional love. For this, we can always seek your mercy. Bless all of us gathered today and send us your Spirit to enlighten our minds and hearts. You who see our distress, who hear our moans, who feel our fear. Strengthen our faith in this moment of uncertainties. Struggle against poverty, disease, hunger, joblessness, pandemic. Struggle against fear, disappointment, anxiety, and worries. O Lord, fill our hearts with your love. Protect our mind with your word. Guide our soul with your spirit. Let your strength work in our weakness. Use all our struggles for our good. O Lord of love, you're able to do immeasurably more than all we ask or imagine, according to your power that is at work within us. Come, be with us, inspire us, and lead us in our time together. We ask this through Christ our Lord. Amen. In the name of the Father, and of the Son, and of the Holy Spirit. Amen. Again, magandang buhay po. Good morning po sa lahat. So, andito naman tayo po for our second part of the webinar. This is the continuation po ng ating webinar last Saturday. And together with me, our moderator, Dr. Shelly De La Vega. Thank you very much po, Doc. Ayan.
Morning po, Sister Cleophie at sa ating mga suki. Talagang maganda na to. Ito na yung pinaka-culminating webinar natin, Sister Cleophie.
Oo, ito na po. Pero ngayon, we have only 37 participants, but hopefully, yung mga iba pa po natin, baka na-late lang po sila. They will be joining with us in a few moments. Sana po. Kasi ito yung pinaka-peak na, tama yung sinabi po ni Dr. Shelly, ito yung pinaka-peak na po ng ating webinar. Pangatlong ano na po natin to, Doc Shelly?
Opo. Pero each attendee here is representing or is accompanied by 5.
By 5 in a community.
Or more community members. So, mas marami pa sa 38 ang nakikinig.
So, siguro, bago po natin umpisan lahat ng mga pag-uusapan po nating umaga, may we call on po our Reverend Father Celito Almazan, the Minister Provincial of the Order of Friars Minor, and at the same time, the co-chairperson of the Association of the Major Religious of the Philippines, to give po ng kanyang opening remarks. Hello, good morning.
Your Excellencies, fellow priests and consecrated persons, our lay partners, esteemed medical practitioners, brothers and sisters. As co-chair of the AMRSP, I would like to welcome all of you to this online webinar 2 on the urgent response on COVID-19 and vaccine campaign among priests, consecrated persons, and lay faithful. This webinar is timely, or perhaps it should have been done earlier to arrest the increase of infections and deaths in our ranks. It is extremely hard to make priests and sisters, and they die just like that because of COVID. And the threats are still there, even those who are already vaccinated. As we who are healthy and surviving are thankful to God for our condition, we must also learn how to continue protecting ourselves and also how to take care of our brothers and sisters in our convents, that they may also be sane, not only in body, but also in mind. In this webinar, the distinguished speakers will tell us how to take care of those with dementia and also those who have become depressed, those whose mental health has been adversely affected. As followers of Christ, we deem to participate in His mission, in His ministry. Our Lord Jesus performed His prophetic ministry not only of preaching and forgiving sins, but also healing. The Greek words used for healing or curing are iaomai, and the more familiar therapeuo. The physician was called iatros. He cured diseases, nosos in Greek, from which the word nausea derives. Jesus was believed also to be out of his mind one time, exeste, out of himself, for he had no more time to rest, so his mother and brothers come to fetch him. Before we get lost in these Greek vocabularies, I'm hopeful that we will learn a lot from our speakers, Father Tex Paurum, S.J., and Dr. Shelly Ann F. de la Vegas, M.D., M.S., and Dr. Maria Priscilla Corazon Diaz Sanchez, who will allow us to enter into their expertise with many more vocabularies unfamiliar to us. Take note, brothers and sisters, after their talks, they will give a quiz afterwards. By the way, at my back is the painting of San Pedro Bautista, who discovered the medicinal properties of the hot springs of Los Baños, Laguna in 1590. Once more, brothers and sisters, welcome po sa ating lahat. Thank you very much.
Participants po natin, and because after this we will have our quiz daw. Tama nga po ba yan, Dr. Shelly? Do we have our quiz after this?
Si
So they
Father
need to be
Shelo.
attentive. Oo. Kailangan nila maging attentive po sa mga resource speakers po natin ngayong umaga.
Apa.
Okay, so Dr. Shelly, ano pang ano natin ngayon sa may mga speakers po natin? What do you think of them?
Napakagagaling po.
Matindi po ba sila magbigay ng quiz po?
Mababait po sila. Mga nakasama ko na po sila ng matagal na sa pag-aalaga ng ating mga religious. Si Father Tech, syempre, Jesuit. Si Father, Sister, si Dr. Priest naman, nag-alaga na rin ng mga Jesuits, RVM, at iba-iba pang mga religious. Ano po? So, sanay na sanay po sila sa topic na ito.
Siguro nga po, na-notice niyo po, Doc, ang participants natin ngayon. Konti lang po sila, baka natatakot po silang mag-take ng quiz natin for the last webinar we have for this day.
Alam niyo po, Sister, it's not really a quiz. I think it's how you will be responding in the next year. And beyond that, no, to the current situation, how to recover to, di ba, and be resilient. Apo.
Oo, kaya sabi ko, na-miss po nilang pinaka-importante po sa may tatlong webinars po natin ngayon. But anyway, just to let you know po sa mga participants po natin, gaya din po ng last po nating webinar, this recorded video po will still be available po sa ating Facebook account. Naka-live po tayo po ngayon, Doc Shelo, sa may Facebook account po ng AMRSP, and they could still view this one sa may Facebook ng AMRSP at the same time sa YouTube po. So for those who missed this webinar, you still have the chance to view this with your community. So yun yung kagandahan po ng media po ngayon, ng platform po na to.
That's very good, Sister Cleofe.
Yes.
Do we have participants from other countries? Because I see that there are some participants here na parang foreign sounding ang kanilang
Oo nga.
Diba?
Nung last time kasi parang umabot tayo hanggang Japan. Meron pa tayong...
Yes, and the USA.
From the US.
Mm-mm.
So ngayon, I don't think so kung meron tayo. Do we have any participant outside from the Philippines po na mga communities natin?
Wala. Last two webinars, there was a request for us to deliver our talk in English because there were participants from Vietnam, from Korea.
Yes, we have from Indonesia.
Indonesia, okay.
Hello po.
Hello.
How would we greet them? Good morning in ano?
Ang alam ko lang, terima kasih.
Terima kasih. That's it.
Terima kasih for joining.
Ayan, thank you for joining. Ayan, so Dr. Shelly, could we introduce to our participant, our first resource speaker for this morning?
Yes, let's proceed with the rest of the program.
Yes.
Now, this is such an important topic, Sister, because we know, as mentioned before, that there were badly hit congregations, and the Jesuits have been the first, I think, to prepare for a pandemic. In fact, even before the pandemic, they were already preparing for it now with a lot of projects within the infirmary there. And so I'd like to really welcome our speaker, Father Tex Alberto Paurom. Now, Father Tex is not just a Jesuit, he's really also a specialist in critical care medicine. No? He's an internal medicine specialist and currently the director of work, Jesuit Health and Wellness Center, Infirmary of the Philippine Jesuits. So please, to talk about pandemic preparedness and what they have learned throughout this past 2 years, no? Let us welcome Father Tex Paurom. Father Tex, over to you.
Hello, Father. Good morning po.
Good morning. I am sharing my
Okay, visible, Father. It's already visible, yes.
Yes po, okay na po.
It's visible, but it's still in presenter view.
Yes,
So,
I'm going to share that again. New share, and then
Slide share sa...
new share.
you can stop sharing this if you want to change to presentation mode.
Stop share.
Stop share muna and then share again
Share
your
again.
presentation mode. Yes.
Advanced presentation mode.
Ayan, okay.
Okay, that's good.
That's it.
Pero hindi eh. It's still in parang presentation view ba yan, Father? Kasi we see your notes in the side.
Okay, I'm going to stop share muna. And then I'm going to basic. I'm going to share.
Apa.
So you can see.
Yeah, we can
Yeah.
see your slides now.
Okay. So just the slides, right?
Just the slides. You are on slide 1.
Slide 1. Let me just make it there. Okay, so good morning again. I'm Father Tex reporting from the campus of the Ateneo de Manila University. I am tasked to talk about pandemic preparedness. If I were to make an apt or a more fitting title of this talk, it would be a journey towards pandemic preparedness. Journey because it is an ongoing process. And with this mutating pathogen, or what we call a moving target, our preparedness, which implies control, is always challenged. We long for preparedness so that when it happens, we will not be unduly harassed and can at least meet the challenge head on. Mind you, we're still in pandemic and surges are still to be anticipated. Take, for instance, Germany. They're able to vaccinate 67.5% of their population. And we think that they are closer to what we call the herd immunity. But currently, not only Germany, but many other European countries are battling a surge of cases, mostly pandemic of the unvaccinated. And in our country, I just Googled this 2 days ago, and we have supposedly vaccinated 35.4% of our population. Of course, it's higher in other areas, like for instance, in NCR, reportedly 67%. Currently, our daily reported cases is going down. The question is for how long? The alert level was de-escalated to level 2 November the 5th. And with more people going out and interacting, we need to closely observe the pattern of this pandemic in our country in the next 4 weeks. Instead of lowering our guards, we should be vigilant and continue to adhere to the preventative measures. In short, we have to be prepared always. So let the title of this talk be A Journey to Pandemic Preparedness. Again, I am Father Tex Paurom of the Society of Jesus. I am also a medical doctor trained in internal medicine. Currently, I am the province infirmarian of the Philippine Jesuits, and I'm in charge of the Philippine Jesuit Infirmary. As an approach, I am using the Ignatian pedagogy, which is the method and practice of teaching and learning. The starting point is experience. I would say we have accumulated enough experience of this COVID-19 pandemic since January of 2020. The experience is the matter of reflection. And the fruits of reflection influence our subsequent action, which again generate new experience or experiences. When we add contexts and evaluation, this would complete the whole learning process. Another way of putting it is we try to see as factual as possible with a trained eye what we are experiencing. Then we reflect and make sense of it based on what we have known. This would lead us to discerning what is ethical, what is a loving action to be done, which would create another wealth of experience. I remember less than a year ago, before the start of this pandemic, in one of Dr. Shelley's rounds here in the Jesuit Health and Wellness Center, she was the one who actually introduced a checklist for pandemic preparedness. Now, this preparedness plan was a response by those who are involved in public health, who have been intuitively certain that any time a pandemic would hit us. Indeed, it has. When the pandemic hit us, it remained actually a checklist. We were caught and prepared. So we have some coping strategies, and true to the Ignatian pedagogy, we studied, we'll read on it, We invited an infectious disease consultant to talk about it and to guide us. We reflected and discerned on what the next best thing to do, and we acted on it. I would like to share with you the experience of my team, how we are managing to negotiate and protect our residents as well as our staff here at the Jesuit Health and Wellness Center in this ongoing pandemic. In this 20-minute talk, I would like to share with you the Jesuit Health and Wellness Center experience of the pandemic and quickly go through the pandemic preparedness checklist. And lastly, where we are at. The Jesuit Health and Wellness Center is the infirmary of the Philippine Jesuits. It is located inside the Ateneo de Manila campus. This is a generous donation of Ramon Isangan family. It is a 4-story building completed in 2016. It has 30 rooms in 3 functional floors. The census fluctuates between 20 to 26 residents with around 50 to 60 support staff. We are a congregate community with very vulnerable elderly and sick Jesuits. If you remember this picture, this is the picture of the Chinese doctor who was working at the center of the outbreak in December when he noticed 7 cases of virus that he thought looked like SARS. Now, this SARS virus that led to the global epidemic in 2003. The cases were thought to come from a seafood market in Wuhan. And he tried to warn the people through his social media about this rapidly infecting disease. Of course, we know that he was silenced and he eventually died of this COVID-19. The World Health Organization declared the outbreak as a public health emergency of international concern on the 30th of January 2020. And on the 11th of March 2020, this was upgraded to the pandemic level. So early on, with so much anxiety, our immediate responses were to discourage and later to really close our doors to visitors. And we enforced among our residents to stay home and stay put. Of course, this was met with resistance in a few of our residents who were still able to do ministry. We then enforced screening, surveillance among our staff for any signs and symptoms suggestive of COVID-19 as they report for their duty. On site, we implemented source control preventive measures like face mask, face shield, hand washing, hand sanitation. We taught proper donning and doffing of the PPE. We gave lectures for the staff on the virus and how we are responding or coping with it. Then we identified an area adjacent to the Jesuit Health and Wellness Center to serve as a quarantine isolation area with planned parallel staffing, meaning dedicated staff with strict or no crossover to the other side. This actually is an anticipation primarily for those who need to be isolated or for residents coming in from the hospital. Of course, we stocked our supplies, both medical and non-medical. We stocked our pantry, of course. Instead of bringing them to the hospital, we started using telemedicine, online consult, and for our medical meeting, we used the Zoom. A few of the priests were not happy, and some felt isolated and lonely. I say a few because more than half of our residents are in different levels of dementia, and I would say that perhaps they couldn't care less. When the COVID-19 cases started to rise and people are dying due to pneumonia, causing respiratory failure, we remember that our president announced on March 12 that the Metro Manila will be placed under ECQ, Enhanced Community Quarantine Lockdown, starting on the midnight of the 15th of March. That was a short notice. With mobility drastically impaired and to prevent carrying the virus inside, we had to institute a major move, and that is to invite our staff in. We have to provide, of course, for food and lodging for like 40 to 50 staff. It has been 18 months now, and the staff continue to stay in after proper screening and quarantine. staying for 2 to 4 weeks straight in a row. And this continues till now. Practically, we created a safety bubble. Safety bubble with strict screening and quarantine for those who come in. Well, we started with actually a 7-day paid quarantine without testing. And then after that, we moved on to reducing it to 3 days, but we do PCR testing. And then following a system from another nursing home, we changed our testing and on-site rapid antigen testing. We do it on day 1 and on day 3 while the staff is in quarantine. And for those who are outgoing staff, they are tested to possibly detect if virus may be circulating asymptomatically among the residents and the staff. We implemented strict screening and surveillance for the staff and residents, monitoring for signs and symptoms of COVID-19, self-reporting. But the more effective actually is peer reporting. When one of the staff would say, "Uy, si nurse is having cough." And so with that, we do immediate isolation, evaluation, and testing. I think that is very, very effective in actually peer regulation, whether somebody may have the virus or not. Fortunately, we have very dedicated staff, kudos to them, and they are very conscientious. After spending several weeks or even months trapped in the Jesuit Health and Wellness Center safety bubble, the pandemic and I suppose being away from their family have a toll on their mental well-being. The caregivers need to be cared for as well. So we allow them to use the gym. We allow them to use the sports facility inside the campus. And of course, I would say a regular walk around the sprawling, empty campus may have been helped. When the vaccine became available, we eagerly applied for it. For our elderly but ambulant residents, we risked bringing them to the vaccination site for vaccination. The staff also were highly encouraged to avail of the A1 as frontliners. And then with the help of Father Rodel Enriquez of the Order of St. Camillus, we not only completed vaccination of our bed-bound residents and the Jesuit Health and Wellness staff, but also extended to the Jesuits and staff of the different houses inside the Ateneo de Manila campus. We had our vaccination early, like April and May. And hindsight, I think vaccination is a game changer. We had our share of COVID-19 outbreaks in our facility, not once, but twice. Well, the baptism was when it happened before vaccination. Remember that we are a congregate community, and we have very vulnerable residents in us. So what happened? The staff was isolated and referred to the LGU, and we were on our toes during these outbreaks, especially during the first, which happened before vaccination. With recommendations from an infectious disease specialist, we did this. Each to his own room, meals were served, no common activities, level 4 PPEs, surveillance, and PCR for all. Luckily, after subjecting all to PCR, only one on the staff tested positive for the virus. We survived the first outbreak, but of course at a cost. The PCR was very expensive. The second happened after a breakthrough infection in one of our staff. Again, the staff was isolated and referred to the LGU. We just followed what we did the first time, which worked. This time we used the on-site rapid antigen testing. So in day 2, we tested everyone, and one other staff was tested positive. On day 5, we repeated testing for everyone. And on day 7, we repeated testing for everyone. With proper masking and distancing, we resumed our daily mass, but no common meals or no common activities till we completed the recommended 14-day facility lockdown. We are now in a status quo, still maintaining a bubble. For everyone, it has been more than 6 months since the second vaccine dose. We are actively pursuing getting the booster dose for the staff frontliners and for our residents for added protection.
The hospitals ito and unmute daw.
Now, this is the checklist for the pandemic preparedness, in particular for COVID-19 pandemic, released by the CDC. The first step is to create a multidisciplinary planning committee or team for planning and decision-making composed of representatives from all departments. Of course, we're talking about the medical nursing, the different services, and the administration. In my case, I frequently meet with my two assistants, one for non-medical and one for the medical concerns. And we have an open line with an ID specialist for quick consult. For posterity and for future reference, it is good to have all this written. This is the tedious part of pandemic planning, but perhaps to be the most important. This would be an articulation of how the proposed checklist is appropriated in one's particular context. These are the nitty-gritty of pandemic preparedness, writing of guidelines and protocols, such as inter-facility transfer, monitoring of residents, review of infection control policies, and what to do when viruses detected in the facility. There are many resources available in WHO, CDC websites. One does not need to reinvent the wheel, so to speak. One just needs to appropriate the recommendations to one's concrete setting. Of course, communication is very important, internally and externally. We have to update our residents what's happening. At the same time, inform the relatives, friends, and other relevant entities who need to know about what's happening in the facility. Of course, the supplies relevant to pandemic, the mask, the face shield, alcohol, disinfectant, PPEs, and of course, the food or the pantry. These are very important in keeping us if the pandemic strikes. And how to manage an ill patient, if positive, what to do. Of course, this is ongoing, and this is the more difficult one, the challenge in our community. And regarding visitors, this is not applicable to us for now, because we closed our doors to visitors early on. But soon, when this COVID-19, as anticipated, will become endemic, then we need to come up with protocol guidelines for visitors as well. Now, care for the caregivers, and I think this is very important. We do screening and surveillance. They do self-reporting and peer reporting. We have to make guidelines on what to do with sick healthcare personnel, the proper use of PPEs, observance of preventive measures. These are some of the things, both to protect the residents and the health worker as well. Education and training for the staff and residents, as well as additional training for the healthcare personnel. Now, the plan is, if there is a surge, what would one do? During one of the upsurge of COVID-19, our preferred hospital was full. So when one of the ailing Jesuit had to be hospitalized, we had to call our friends, meaning to say our connections. We have our isolation and quarantine nearby. We not only think of the residents, but of the staff as well. In fact, our quarantine isolation area has been of use to the whole community here at the Ateneo de Manila campus. Now, I have to admit that this remains a weak point in our preparedness. If the hospital are full and we are forced to manage at least the moderate to severe cases in our facility. The supplies, medical, non-medical, and that means food. And what happens when one dies. So it's really a comprehensive checklist on what to do during pandemic, especially, and this particular checklist is for COVID-19. In summary, we are instructed to create a committee. But we are a small facility, so it is not very difficult to identify, assign, and gather the heads of the different departments and services. But I rely mostly with my two assistants, who are both nurses and who are readily available to discuss and brainstorm what to do. We have kept a bubble that works and protection for both the residents and the staff. We still keep our staff in after 3 full days of quarantine with testing on day 1 and day 3. Observance of the preventive measures is highly recommended, and we actually ensure that they do follow. Strict screening of those who come in and surveillance of both residents and staff who are in the bubble. Again, now we're in a status quo, still managing a bubble. For everyone, it has been more than 6 months, and we are really pursuing this booster because this would be an added protection both for the residents and for the staff as well. Now, what are the weak links? When the hospitals are in full capacity and we are forced to manage moderate to severe cases in our facility, this would be something that's scary. I don't think we're prepared for that. And of course, about the staffing. Fortunately, the staff are so good. They're so generous. But I suppose that if one is sick and we have to, the bench, it's difficult to find a replacement. And staffing would be a weak link. This would be a challenge in pandemic preparedness. Of course, threat to our bubble. We do have some errands that needs to be done. So we have a weak link who goes out of the bubble to buy something that's important or requested by the patient. Some of the patient need to go out for face-to-face visit clinic. And so we don't know. The virus is in the hospital and who knows, he might be bringing the virus into the community. And lastly is mingling with other residents inside the Ateneo campus. You know that we have outbreaks inside the Ateneo. So this virus really is in and out of the campus. So we have to be very careful of keeping the bubble of the Jesuit Health and Wellness Center. There is a saying that a pandemic is like a forest fire. If caught early, it might be extinguished with limited damage. If allowed to smolder undetected, it can grow to an inferno that can spread quickly beyond our ability to control it. So again, we have accumulated enough experiences. We have reflected on it, decided on what the next action would be, and we know what to do in keeping the integrity of the bubble. That is the Ignatian pedagogy, to see scientifically, reflect spiritually, judge ethically, and then act concretely. We continue to explore the weak links and find ways to address it. The challenge now is to find time to sit down and write down our experiences and how we can be prepared for the future pandemics, so that those who will follow us will have something to refer to when the next pandemic happens. And we will not be unprepared, hopefully, the next time it comes. Again, thank you for listening. Have a good day, everyone.
Thank you so very much, Father Tex. What a wonderful sharing from someone and from a group that has really prepared and continues to prepare and reflect upon what the pandemic really means for our religious communities. No? We know that many of you who are here have been equally affected, some to a greater degree than others, but some of you really still have the time to prepare. And this is what we have learned from Father Paurom. We will have a question and answer portion later on. I hope, Father Tex, you will be available. Are you still available later for some Q&A? Thank you.
I'll be here.
But for our participants, there is a Q&A box that you can start typing your questions there, and we will address them later on. Hopefully, we will have a lot of time for Q&A. So, I am the next speaker, Sister Cleo.
Yes! Akala ko, diretso mo na.
Hindi. Sige, pwede nang dumiretso. Sige, ikaw muna. Sige,
Pwede
Sister
na
po.
rin. No. Thank you very much, Father Tex. I was very touched when you say that you're very been careful in keeping the bubble, the safety bubble, no? Na ano pa ako dun sa safety bubble po na ginawa po ng mga Jesuits community nila, no? Thank you so much. So, the pandemic is not yet over.
Yes,
We
not
still
over
need
yet.
to prepare that, no? Kaya itong natin, yung last webinar natin, series of webinar, this is what we call the sana yung mga communities natin after this series of webinar, they could also create that plan as what Father in their community did, no? maingat talaga sila. Kaya sabi natin, we are still fighting the pandemic. It's not yet over. We are still need to equip ourselves by this. And we are very grateful for our speakers. And of course, no, sa ating next speaker, kasi as what Father have told us, there's mga consequences po na nangyari, not only to the community of the sisters or the priests, but also sa lahat po ng mga Pilipino and even people throughout the world. We are confronted with what we call psychological effect due to this pandemic. And it's really timely po to hear inputs and knowledge regarding on how are we going to cope this up. So our next speaker joined us and supported us from the very beginning po ng ating webinar. And we really appreciate for her dedicated effort, support, and love to the religious just to come up with this series of webinar. You know her very much, of course. So our next speaker po, she is presently the director po ng Institute of Aging, the National Institutes of Health on UP Manila. And of course, my co-host for this morning. My dear sisters and brothers, please help me, our very own Dr. Shelly Ann de la Vega.
Thank you, Sister
Ayan.
Cleofe.
Ayan, ready
yun.
na ang kanyang
Ready na yung
slide.
slides ko. Thank you very much again. You know
Here po.
that, as Sister Cleofe had mentioned, and I'm sure you have experienced how some of your members who are experiencing dementia have gotten worse during this COVID pandemic. And not only that, yung mga wala pang dementia, parang may dementia na
May
ngayon.
dementia.
Di ba, Sister Cleofe?
Totoo.
Ang dami kong pasyente nagpapakonsulta, Dok, nagde-dementia na yata ang nanay ko. O ako, Dok, may dementia na ba ako? Kasi starting the pandemic, nagiging makakalimutin na ako. Hindi ko na alam yung gagawin ko. O kaya yung kamag-anak nila, no? Si nanay o si tatay, parang paulit-ulit na at saka laging nagagalit. Ano ba yan? Dementia ba yan? So this is what we are going to talk about, no? Caring for people with dementia during COVID and even beyond COVID, no? We will discuss that. So the objectives are to describe dementia and what a dementia-friendly community is, no? Because we need to prepare not just the patient, but the congregation and even the family and the community around us. We will discuss the role of the community in supporting people with dementia. We will also discuss how healthy aging programs help in preventing dementia. How is healthy aging linked to dementia prevention? Is there a correlation, or is this something that we need to discover again? No? And of course, to identify community resources for dementia prevention. Okay, so dementia is a disease that affects memory, daily function, and personality. So it's not just forgetting your friend's name or forgetting where you put your ball pen, but eventually, if it is truly dementia, it should affect how you take care of yourself. For example, you no longer know how to dress up, you no longer know that it's time to eat and even how to prepare your meals. And at the worst cases, you now will be needing the help of a caregiver to give you your food or to feed you, to bathe you, to dress you up. No? And it is a deadly disease because towards the end, dementia will make the person bedridden, and it affects many parts of the brain as the brain shrinks. No? Okay, dementia proportionately increases with age. So the more older persons you have in your community, the more dementia patients we will be expecting. So if you are an aging community, for example, you have 30% of your community members beyond age 70, then you will be expecting a higher rate of dementia in the next couple of years, no? Because that increases really with age. If you are age 90 years, there is a chance that you will have dementia by 50%. So 50% chance there, just by the age alone. And there are irreversible risk factors, no? These are things that we have not yet found a cure for, no? Of course, females, aside from increasing age, female sex is a predisposing factor to dementia. And many of you in this webinar now are women religious congregations, so you need to prepare. And of course, there is that genetic predisposition, no? For example, ApoE epsilon 4, but this usually occurs in certain groups of people, especially if you note that a family member had dementia at a very young age, some of them even at age 50. No? Okay, so this we cannot do anything about at this time. Maybe in the future where there are some scientific discoveries on genetics, etc., we may be able to deal with that. So there are risk factors in the recent Lancet Commission 2020 report. And these risk factors vary as people age. No? So let's see. Below the age of 45, less education is a risk, increases the risk for dementia. So those of you with younger members, please continue to learn. No? But learning shouldn't stop as we age. Older people, even those with retired, are encouraged to learn new skills, learn new languages, who knows, no? And even enroll in colleges and even schools like schools of theology, etc. By the time you are 45 to 65, by midlife, the following were determined to be risk factors that we can deal with as a community. No? Hearing loss, traumatic brain injury, those who were in accidents, no? Hypertension that continues to be uncontrolled, alcohol drinking of more than 21 units or 10 ml per unit per day, no? And obesity. If the body mass index, kilograms divided by height in meters squared, is more than 30, obesity will be a midlife risk for dementia if you continue to have all these things as you age. Now, for those age 65 and older, at later life, smoking, tobacco, depression, and that will be tackled by Dr. Pri Sanchez. No? Smoking, depression, social isolation, especially the lockdown. Physical inactivity, again, the lockdown. Diabetes and air pollution are all contributing to an increased risk of dementia. Okay. So, by the way, there are some links here in the bottom of my slide. You can go to those links, check these resources. Okay, so in essence, when we talk about dementia prevention, we really are talking of two things. To the left, we are talking about reducing neuropathological damage to the brain. And to the right, increasing and maintaining cognitive reserve. So we will prevent dementia if we continue to enrich our brains and continue to protect the brain reserve that we have. And how do we do that? Reduce neuropathological damage by minimizing diabetes or managing it appropriately. Treat hypertension, prevent head injury. Those of you who are drivers, make sure that you have a helmet if you use a motorcycle, and use a seat belt every time you drive or if you ride a car. Stop smoking, reduce air pollution, and reduce midlife obesity. And to the right, increase and maintain cognitive reserve by treating hearing impairment. So if someone has a hearing impairment, make sure they get checked. Baka tutuli lang yan, baka impacted sa rumen lang. But if they need a hearing aid, then maybe that would also be helpful. And maintain frequent social contact. And that is what is good about congregations, isn't it? You really get together regularly to have meals together, to pray together, and have many activities together. And hopefully the pandemic will allow us to eventually do this, no, in better ways. And of course, try to attain a high level of education. So in the middle are commonalities, no? Commonalities to those two, no? If we frequently exercise, if we do reduce the occurrence of depression, and if we avoid excessive alcohol, then we protect the brain and maintain the brain function that we have. So remember this, the one in the center that really covers both sides of dementia prevention. So in summary, for the community that you are in now, the community can enhance and try to improve early education. And I know a lot of you have schools, no? And you would like to make sure that you continue your very good work in schools, and advocate for social public health programs to reduce hypertension, such as less sodium in our food, no? And good diet practices. And please support policies that encourage social, cognitive, and physical activities through the lifespan. And it's not just DOH here, but your LGU that you should support, your community, your barangay. Many of you work in NGOs too, right? And you can do that too as a congregation. And so there are many other things that we can do. Some of these have to do with research, studying more about hearing loss and how to reduce the risk. And then again, of course, have policies and programs that reduce the risk of traumatic brain injury. For example, we have a helmet policy. We have a seatbelt policy. We also have occupational policies that protect our workers where they are, no? And of course, national and international policies to reduce air pollution. And many of you I know are very active in climate change and environmental you are in NGOs that protect the environment and speak for the earth. So please continue to do that, no? And of course, reduce exposure and uptake of tobacco and smoking cessation. Okay, how do we prepare for a dementia-friendly?
Dementia-friendly.
Okay, can we, sorry po, there are some participants who are unmuted and we can hear you. So please have your microphones off. Thank you. So how do we prepare for a dementia-friendly community? So what is a dementia-friendly community? It is a community, city, town, or village where people with dementia are understood, respected, and supported. So it's similar to the first talk that we had heard about ageism, diba? We don't want ageism. And it's a same kind of discrimination. So we want to create dementia-friendly communities where they are. And a dementia-friendly community will allow a person with dementia to live well, to age well, to actively participate in their community, are valued, no, and thrive despite the sickness of dementia. So what are the community resources that you can use, no, and you can avail of to make your congregations dementia-friendly? Now, the World Health Organization Western Pacific Region Mental Health Unit funded the Dementia Toolkit for community workers in low and middle income countries. So this Dementia Toolkit is available for free, and I will share to you some of the links that can bring you to those sites where you can access and download this workbook. So it is not just for health workers. These really are for you. Those who work in communities, those who volunteer in your barangays, in your churches, etc. No? So this is really for you. It's written in English. And it was published, I think, 3-4 years ago. So these are some of the resources in that toolkit. It lists several things that you need to make sure that you have, no? Similar to the pandemic checklist that was shared by Father Paurom, that there are individual resources that you know and are able to identify: medical, nursing, social care, dental, and spiritual resources. And you need to also link to organizations that have some work or are continuing to work for and advocate for dementia. Many of these can be faith-based, charity organizations. There may be some already in your barangay, some NGOs such as the Alzheimer's Disease Association of the Philippines, no? Foundations, schools and universities, and professional societies such as the geriatric societies that we have, the Alzheimer's Disease Association, the Geriatric Nurses Association. So we have that listed, no, in our resource. So we also need to create dementia-friendly places and spaces within our churches, areas where they can walk, where they can sit quietly if they want to attend Mass, senior citizen centers, daycare centers even, no, where they can convene and have activities that enhance their mental health, such as crafts, arts and crafts, animal, for example, pet therapy, art therapy, music therapy, and of course, shopping centers that need to understand that sometimes kasi when a person with dementia goes shopping, she doesn't know anymore that she is overspending, no? I don't know with you, but we know that there are certain religious who have a budget and they are given a budget to spend. And sometimes they no longer know how to spend it. They overspend, or they spend their entire budget for the month on things that may not be helpful to their health or not even useful to them. So you need to also take care of that. And of course, parks and restaurants that will understand and accept them. Home safety is also very important for those with dementia. So these are in greater detail. I'm just showing this to you because we have now translated, we have translated parts of the Dementia Toolkit into Filipino. And so there are home safety tips there for hagdanan or stairs, sahig or floor, kusina or kitchen. So there are some questionnaires that you can go through to make sure that these are safe, not just, by the way, for persons with dementia, but also for older people and those with disabilities in your community. Now, how do we support persons with dementia in the time of COVID? So COVID is something that has affected all older people, especially those with pre-existing medical conditions, including dementia. And because they are old and have multiple medical problems, including dementia, they have become more vulnerable and have a higher risk for hospitalization and death from COVID. Furthermore, COVID quarantine or lockdown, as we know it, have increased the risk of older persons for mental health problems, sleep, anxiety, depression, cognitive decline, social isolation, neglect, and even abuse, by the way, no? Fear, stress, and loneliness affects older persons' resilience and further jeopardize their well-being. And these are some of the findings that we had shared in our policy brief on COVID-19 in the Decade of Healthy Aging, research by the Institute on Aging Fit for Frail project. So in that Fit for Frail research project, we also found out that there are a lot of people who do not know that they already have dementia. So unless you get them checked, we will not know, because they may have self-reported symptoms of dementia, but because they have no access to a professional, they will not be adequately diagnosed. So dementia, anxiety, Alzheimer's disease. There is a variation in the self-report of symptoms. Some of you may think you have dementia, but hindi naman pala. So this is why you need to consult a physician. So there's a difference also in the self-report of sleep problems and cognitive impairment, no? So some of them who do not know that they already have cognitive impairment, maybe it's because the cognitive impairment is there, they do not know enough to consult. So make sure that they consult, that you facilitate their consultation with a physician. No? Okay. These are some of the challenges of persons with dementia during COVID. They are unable to follow hand washing and wearing of masks and quarantine. Of course, depending on the stage of their dementia. The more moderate and severe cases, of course, will no longer be able to follow, even if it's already posted, no? And I know that in the Jesuit infirmary and even some of the infirmaries that we work with, we have already been posting hand washing posters there, how to wash your hands properly, that you need to wear a face mask, etc. So isolation, no? They will become more confused and depressed, and because they lack exercise, they will have more weakness and be prone to falling and imbalance. And because of the limited access now to face-to-face medical consultations, we really have fewer patients checking in with their doctors, and medication access becomes a problem because the prescription may be very old and the drugstores may no longer want to give the medicines out, right? And of course, caregiver stress. That has been highlighted also by Father Tex. So this dementia toolkit for community workers, like I said, is available for free and has been translated. But we also were able to create a webinar series of living with dementia during COVID. So please take note of this YouTube link because I cannot discuss it. There are so many things to talk about. And we have experts here in this YouTube series that will talk about dementia and COVID, the infectious disease part of it, the support, no? Hospitalization support, and nursing home care. And these are really very good speakers. Furthermore, we have other topics that we covered, no? Depression being one of it. And Dr. Pris Sanchez is here to talk about it later on. No? So we also are preparing for some policy briefs. So we want you to also take a look at the screen and take a screenshot or go to that QR because that QR code will send you to our webpage. And our webpage will send you to the resources that we have for free, including posters that you can post on dementia, including the parts of the COVID seminars that we gave. And soon, very soon, we will have the Filipino versions there in our webpage. So make sure you know that QR code and go to that resource, okay? So there are certain tips for the care of persons with dementia during COVID that are in that webpage and those seminars. And some of these, in summary, are for you to help them maintain their routine. No? Persons with dementia need structure. You cannot keep on changing their routine because they get more confused and can be agitated if you do not have a routine and a schedule for them. So know when to schedule their hygiene, when to take a bath, take their meals and medications, prayer time. And if you can, post them in a to-do list where they sleep or where they are. And of course, we want to restrict face-to-face visits until your area especially has been declared low risk. No? And use social media as much as possible. Link them through Facebook, through Viber, FaceTime, etc. Use social media to help them link with other members of the community and their families as well. And then post photos in where you are on how to wash hands, that they should wear masks as reminders to them, and make available in many areas your alcohol, your tissues, and your sanitizers. And if you find that they are getting more aggressive and agitated, make sure that you address this. And it may be a sign of pain, or of hunger, or of a heart attack. Pwede pala, no? And if they start losing their appetite or they start looking weak, then you may be looking at someone who already has COVID or an infection. So make sure you have a doctor that you can easily access to consult. No? And of course, for those of you who are taking care of persons with dementia who are very end stage, already bedridden and non-communicative anymore, discuss the advanced directives. We will need this, especially if they have COVID, because that has already happened. No? Will you hospitalize them if they are already bedridden and non-communicative? And will you even vaccinate them if they are already demented and already bedridden and non-communicative? So these are issues that you need to discuss. Hospitalization, do not resuscitate, or that means cardiopulmonary defibrillation, for example, and intubation, ventilation support. And you really need to talk to families and even the community, because the community can hurt if they know that their friends were not sent to the hospital and were not vaccinated. It can be very painful, not just for that patient, but for the entire community and of course other family members. Okay, malusog na pagtanda. is already translated, as we said, and will be available in our webpage. So finally, let's review. You heard about healthy aging and dementia prevention. And I am here to say that healthy aging equals dementia prevention, because we can just look at the list and this slide that I shared with you earlier and highlighted in yellow are what constitutes healthy aging. In the middle is frequent exercise, reducing the occurrence of depression, and avoiding excessive alcohol. And these will help minimize diabetes, treat your hypertension, no? Stop smoking, also reducing obesity, and maintaining frequent social contact. These are all healthy aging practices, and these will all lead to dementia prevention. So again, we describe dementia and a dementia-friendly community. We now understand the role of the community in supporting people with dementia. We now know that healthy aging is dementia prevention, and we have identified community resources for you to go to for dementia prevention and dementia-friendly communities. So healthy aging equals dementia prevention, and we are in the decade of healthy aging. So 2020 to 2030 is a decade for healthy aging. So happy healthy aging to everyone. Thank you very much.
Okay.
Thank
So
you.
Thank you very much, Dr. Shelley. So healthy aging, my dear sisters and brothers, is equal to dementia prevention. What a very nice topic. Most of the time we greet our elder sisters na, happy birthday. Let's continue to grow graciously. So growing graciously is also being free from dementia. So it's good to create a community. Ayan. I was in video of sorry po. So it's really good to create, my dear sisters and brothers, a community, a friendly community free from dementia. Most of the time, this is our problem within the community. Actually, Doc, that's our problem. And how to deal with our elder sisters, to be patient, caring with them. You know what? It could sometimes be a problem. It could also be a joy to the community. The sisters know that, and they could understand me. They could really get what I really meant when we deal with our elder sisters. So it's good to have this topic, Doc, particularly during this time of pandemic. Thank you so much. It's very substantial and very beneficial to our dear sisters who are with us this morning, because most of us are now suffering from the elderly. Most in our community, Doc, most of our sisters in the community are already aging 60 up. So not only in our community, but also in some other congregations, we have that. And that's the common situations now of the congregation, both in women and then the men religious. Okay, so thank you so much, Dr. Shelley, for that wonderful and very beneficial topic for us this morning.
Thank you.
Yes. I think we need to proceed for our next speaker.
Now, Dr. Maria Priscilla Diaz-Sanchez, or Pris as we call her, is someone who has been working with older people in religious communities, female or male, for the many years, more than a decade now that I have been working with her. So Dr. Pris Sanchez is a consultant in internal medicine and geriatrics at the Medical City. And she now works mostly in the South, di ba, Pris?
Right.
So she stays mostly in the South. And she's also a consultant in the Institute for Wellness and Aesthetics in the Medical City. And, you know, Pris is not just a geriatrician, but she also teaches in the Ateneo School of Medicine. And whenever we have webinars, no, she's also a well-known and respected speaker, no, for geriatrics. So let's welcome now to talk about depression, no, Dr. Pris Diaz-Sanchez.
Okay.
Thank you so much, Dr. Shelley. Thank you also for asking me to speak today. I have well-loved and sorely missed uncle who was a Jesuit priest, and Father Tex Paurom and Dr. Shelley and myself, we worked together to take care of him, and he lived well into his 90s. So it's very wonderful and very important to me to be able to contribute to the improvement, maybe, or in the illumination or addition of educating of members of religious congregations, in hopes that it will help us get through this pandemic better, in a better mental health as well as physical health. So my topic for today is to talk about one of the most devastating consequences of the COVID pandemic, which is its toll on mental health, particularly depression. Now, the topic is primarily depression, but please remember that there are other mental health disorders that have worsened with the pandemic, such as anxiety disorders, substance abuse, dementia, as Dr. Shelley just discussed, and even post-traumatic stress disorder in some cases. So let's start with some definitions. According to the American Psychiatric Association, depression is a common but serious medical illness that negatively affects the way one feels, acts, and thinks. It can lead to a variety of emotional and physical problems that can decrease one's ability to function at work and at home. Now, although there are multiple parts in diagnosing depression, there are two core features, which are a persistence in the depressed mood and a diminished interest in or pleasure from activity. So there's a time interval, which is 2 weeks. If it's less than that, then it doesn't really strictly fall within the diagnosis of depression. But also important is a decrease in the interest in doing things that made them happy before, like going to the mall or playing basketball. If there is a diminished interest in these previously pleasurable activities, that can be a very important marker for the presence of depression. So the following are the common presenting signs and symptoms of depression. There are multiple persistent physical symptoms with no clear cause. We doctors are very, very used to seeing patients who come in with vague but numerous complaints that for which we do a whole battery of tests pero wala kaming mahanap na cause. So this is a common presenting sign of depression. There's also low energy and fatigue. They don't like to get out of bed. They don't like to perform their usual activities, even the routine activities that they've done in the past. Sleep problems, either too much or too little. The presence of anxiety or constant worrying over things that may not really be, that may seem trivial to other people. Change in appetite or weight. Sometimes you see patients who have lost a drastic amount of weight. And on the other hand, those who have gained an extreme amount of weight as well. So these can both be signs of depression. And they talk about feelings of worthlessness, feeling worthless, feeling guilty, feeling indecisive, and always being restless or agitated. And of course, hopelessness and suicidal thoughts and activities. And acts, sorry. So to make a diagnosis of depression, the symptoms must last at least 2 weeks, as I mentioned earlier. And it must represent a change in their previous level of function. The things that they were doing before, they can no longer do or have no will to do. And medical conditions can mimic depression. So among these are thyroid disease, usually hypothyroidism, which is one of the things that we rule out before coming up or labeling a person as depressed. The presence of brain tumors and vitamin or other nutritional deficiencies. So these organic or physical medical conditions should be ruled out before labeling a person as depressed. And also, one must differentiate grief or bereavement from depression. The symptoms may be similar, but there are distinct differences because one, the grief tends to be more short-term and comes in waves. It doesn't stay there. Whereas depression is a persistence of the low mood. And oftentimes in grief, there is a maintenance of self-esteem. They don't think badly of themselves. Whereas in depression, there's a feeling of worthlessness, a feeling of self-loathing sometimes in some cases. Now we go to risk factors for depression. The first of these is in terms of biochemistry, in which there are imbalances in usual neurotransmitter levels, particularly dopamine, serotonin, and to a lesser extent, norepinephrine. So these neurotransmitters play a role in the development of depression. And actually, the drug treatments are targeted towards these neurotransmitters. Now, also genetics, depression can run in families. There have been numerous twin studies done in the past showing that if one twin is depressed, the second twin is 70% likely to develop depression as well at some point in their lives. A third risk factor is personality. First, there are people who have low self-esteem, whether from familial exposure to abuse or which makes them less able to manage stress, or makes them easily overwhelmed by stress. And also those who are generally pessimistic, they are more prone to develop depression. And of course, environment, people who are exposed over a long period of time to violence, abuse, and neglect, like in war-torn nations or those in abusive households, and maybe to a certain extent, our present situation as well. The COVID pandemic can be considered an environmental factor that can predispose us to become depressed. Now, in terms of numbers, pre-pandemic, the WHO said that there are 280 million people who are depressed in the world, or 5% of the global population. It is the most prevalent mental health problem among seniors, okay? And it affects 7% of the world's senior population. But remember, this is pre-pandemic. It's sadly often underdiagnosed and untreated in primary care, where the focus of most physicians is on diagnosing and managing physical complaints. And moreover, not all primary care physicians are adept at recognizing the signs and symptoms of depression. So the WHO is conscious of this disparity, so they have developed training manuals for primary care physicians so that they will become more comfortable and more adept at recognizing mental health issues, not just depression, but also dementia, substance abuse, and anxiety disorders. So depression is a very treatable disease, but unfortunately, again, between 76 to 85% of the depressed people in low to middle income countries are untreated. And of course, the Philippines is one of those. Over 700,000 people die of suicide every year worldwide. And unfortunately, again, suicide is the fourth leading cause of death among this young population, those aged 15 to 29 years. Now, with the advent of COVID, people have been faced with a new set of major stressors. And among these are an actual threat to life. We're all aware that we're going to die someday, but for most of us, it's something nebulous, something that will happen eventually, right? But when COVID came along, it became a very real possibility, something that could affect our loved ones, our family members, and ourselves. You know, it could hit us anytime, could happen to us. So that was a new a new stressor when COVID came along. Another is the imposition of unfamiliar public health measures, mask wearing, shield wearing, physical distancing, and staying at home. And the last of this is, in some countries, would be considered an infringement on personal freedoms. So again, that's another stressor. And of course, large and growing financial losses because of lost opportunities to generate income. Even seniors need to have income. And many senior citizens continue to work. But because of the imposition of the public health measures, there is a lost opportunity to do these things. Also, another source of stress is the conflicting messages from those in authority. And in some cases, this can lead to mistrust, even of healthcare workers, because people say one thing, like ivermectin or other unproven treatments, which the doctors would not really prescribe for them. So it can foster a sense of mistrust even in between the patient and the physician. So these have led to widespread emotional distress and increased risk for psychiatric illness. Now, there are certain groups that have been identified that are more vulnerable to the effects of pandemics, to the mental health effects of pandemics. And these are those who have contracted the disease. We all know people who have gotten sick, who have developed such trauma, such damage, psychological damage from being intubated, being isolated from their families, and fearing death, impending death. So they are very high risk for developing depression. And those at high risk for it, particularly the elderly and the immunocompromised, those who already have pre-existing medical conditions, those living or receiving care in congregate settings. You are considered a vulnerable group in the development of mental health problems. And those with pre-existing medical, psychiatric, and substance abuse problems. So this slide shows the large increase in the prevalence rates of depressive symptoms in the OECD countries, which are the richest countries in the world. So these numbers are from early in the pandemic. Number one really is Sweden. Pre-pandemic, the prevalence rate of depression in Sweden was 11%, but in 2021, it jumped to 30%. So these are numbers from other countries as well. Of course, these numbers are early this year, maybe the second quarter of 2021. But in the United States, a Brown University study was released recently, and it was published in the Lancet, actually, in October 2021, which showed that depression among American adults persisted and even worsened over the first 1.5 years of the pandemic. This is considered surprising because the usual response to things like hurricanes or major disasters is a waning in prevalence rates of depression as time passes. But you can see here, 8.5% pre-pandemic, 27.8% in 2020, and this year, 32.8%. So even in the United States, many parts of the United States have gone back to normal living. Depression persists and has even worsened. So this is a cautionary tale for us as well, because it might happen to us as well in the future, and it's probably happening as well. In the Philippines, early in the pandemic, a survey was conducted, which included 1,800 respondents. So they used two validated tools, the DAS-21 and the IESR, which I will describe in more detail in the next slide, because I think they might be useful to you. According to this survey, 17% of respondents developed moderate to severe depressive symptoms, whereas almost 29% developed moderate to severe anxiety, and 13.4% had moderate to severe stress. It also identified the demographics that were most likely to develop these depression, anxiety, or stress. And these were females, young females, particularly students. Protective factors included adequate health information, having grown-up children, perception of a good health status, and confidence in one's healthcare provider. So as I mentioned, these were the two tools used in that study done in the Philippines in 2020. The IESR is the Impact of Event Scale revised, which is 22 items graded from 0 to 4. And it is a self-reported scale, but it focuses primarily on screening for post-traumatic stress disorder. And some sources claim that this tool is not really appropriate for use in viral pandemics. What is more interesting is the DAS-21, which is the Depression Anxiety Stress Scale. The 21 is a shortened version of the full 42-item screening tool, which is graded 0 to 3. It's also self-reported. And in the DAS-21, there are 7 items each to screen for depression, 7 for anxiety, and 7 for stress. So this can be used in clinical and non-clinical settings. Just as a matter of interest, in the study itself, the mean DAS score was 25.9, with a quite large standard deviation. But this falls within moderate to severe depression or anxiety or stress. Okay. So I'll provide a link later for how to access this, because this is something that maybe can be used in your particular setting. A recent press release from the DOH Disease Prevention and Control Bureau in May of this year revealed that at least 3.6 million Filipinos are battling mental health illnesses. And this table shows that by far the most common of these is depression, followed by alcohol use. So the bureau chief, pictured here, Dr. Cuevas, was quick to describe these numbers as an understatement due to underreporting. So in all likelihood, these numbers are higher. Now, a review article published in April of 2020 identified the following unintended consequences on mental health of lockdown or quarantine, particularly for the elderly. First is depression and anxiety. 37% of the elderly in China were found to have depressive symptoms and anxiety. And a disruption of the day-to-day routine would lead to a negative impact on cognition, on thinking processes, and quality of life. Also, as being in a state of continuous worry about routine and lack of social connectedness led to heightened stress and a decrease in coping skills. Another unintended consequence is unmet spiritual needs. So the prohibitions to church going and being unable to commemorate important religious events like Easter increases the elderly's sense of isolation and disconnection from their spiritual leaders and church peers. So for a profoundly Catholic nation like ours, this is a deep wound for this population of people. Another is poor social well-being due to social distancing and stay-at-home mandates. So this is particularly seen in geriatric people who are not quite adept at digital communication. So because they are encouraged to stay at home, there is an increased sense of isolation and reduced mobility, and again, reduced opportunities to generate income. Another is a decline in physical well-being due to a reduction in physical activity and increased more exercise, which are of course linked to increased morbidity. Now that COVID numbers are down, we find ourselves facing a flood of patients coming in for non-COVID problems. They didn't want to leave their homes before, or they weren't allowed to leave their homes before. So now they're coming in with serious non-COVID issues such as heart attacks, strokes, uncontrolled diabetes, uncontrolled kidney disease requiring dialysis, and even cancer. So what can be done? What can we do for depressed people in this time of COVID? The first thing to do is to identify depression, or at least the possibility of depression. Now, for this, we go back to the core features which we mentioned earlier, which is the persistent depressed mood and a markedly diminished interest in or pleasure from activities. And keep in mind also the more common signs and symptoms, which I showed in one of the earlier slides. When trying to diagnose or identify, let's not use the word diagnose, which is something that probably a medical professional would have would be limited to a medical professional's vocabulary. In order to identify symptoms of depression, you should also consider the duration of the symptoms, which, as we mentioned earlier, is 2 weeks, and its effect on daily functioning. Like, is there a reduced ability to carry out their daily tasks? Like if they have roles or chores that they do within the congregation, is there a decrease in the ability or a decrease in the willingness to do it? It may even, patients might even find it hard to get out of bed or to bathe or to get dressed. Okay. But if the mood is persistently low, if the patient remains functional, he may not have depression per se, but another mental health issue that may still require intervention. Excuse me. Once depression or the possibility of depression has been identified, the next logical step in our setting, at least, is to refer to a mental health professional for further assessment and management. But there are some interventions that can be carried out early and in concert with actual medical psychiatric management. So I'd like to show you the management hand for depression, which is found in the MHGAP training manual for mental, neurological, and substance use disorders. Okay, so this is a project of the WHO, I mentioned it earlier, in order to help train primary care physicians in at least identifying the possibility of mental health disorders such as dementia, depression, anxiety. So these are the interventions that are available for depressed patients. And one or a combination of these interventions may be used depending on the characteristics of the patient. So the first is psychoeducation, in which you educate the patient regarding what depression is, what it means, assuring them that it's common and that it's not a sign of weakness or laziness, but it's an actual medical illness that is very treatable. Another is reducing stress and strengthening social support, which may entail encouraging the patients to do activities that used to be fun for them. Remember, that's one of the core features that they do, that they stop doing things that were previously pleasurable for them, such as going for walks, doing cooking, helping out in the cooking, things like that. And also encouraging them to solve small problems that are well within their ability. So this will achieve short-term success for them and maybe help to bolster their self-esteem as well. And also reassure them that it is okay to ask for help from their friends and family. Another management option is promoting functioning in daily activities, which means encouraging tasks to develop a routine and a structure. So going back to developing a routine is very important, not only for depression, but for dementia, as Dr. Shelley mentioned. It's motivating and gives short-term satisfaction, which is a good step towards improving the overall mood of the patient, as well as their improving their ability to cope and to improve their self-esteem as well. Now, included here in promoting functioning in daily activities is encouraging sleep hygiene. One of the common symptoms of depression is sleep disorders. So simply setting up set sleeping time or set waking time would be a very important aspect of promoting functioning in daily activities. Another is focusing on regular meals. There are some who say, I don't want to eat, I'll just stay in bed. So encouraging the intake of regular meals and partaking of exercise, especially now that we can already leave the elderly and all of us can actually go out already of our households. It's good to encourage physical activity. Now, these psychological treatment and pharmacotherapy fall within the purview of the mental health professional, of course. Now, these interventions can be adapted to COVID. Psychoeducation in the time of COVID entails explaining the effects of the pandemic on the mental health of various populations. So this kind of understanding may provide context and reassurance, and that can lead to a reduction in anxiety and the return of hope, which is essential in managing depression. In terms of reducing stress and strengthening social support, as I mentioned earlier, it's easier now that quarantine measures have eased. So spending time with the family and friends is also possible. Doing activities together is a potent intervention in helping to improve the mood and functionality of patients who are depressed. And promoting functioning in daily activities also becomes more possible as people can now engage in more exercise and follow a routine and break away from the thrall of social media and virtual interactions. So this final slide lists the hotlines for urgent to emergent mental health concerns, which is under the purview of the DOH and the National Center for Mental Health. So I hope you have these numbers ready in case you need them. And that's the end of my lecture. Thank you so much for your attention.
Thank you so much, Dr. Chris Sanchez. And now it's time for our question and answer portion.
Yes, we have some questions in the Q&A, Doc.
Yes, let me read out that question because I would like the members, well, aside from Father Tex, I think, who can answer this based on experience, I'm sure that other members of congregations who are in this webinar now can share their experience. So the question is, how do we motivate our lay mission partners to be vaccinated aside from continuous education? Thank you from the Franciscan Sisters FFIC. So maybe Father Tex, that was a good question, and I think you have experienced that, no? Because the Jesuits have many lay partners there. How did you convince them to get vaccinated, Father Tex?
Well, at least for the workers, for the staff, it is easy because they are motivated. But I think we have to remember that the 35.4% and my friends in Bukidnon are actually sensing that the vaccine hesitancy is actually increasing. There are many Filipinos who do not like to have the vaccine. So I think first is education. We have not educated them well yet. That's number one. Second is, I think we will just have to emphasize that the current surge is more of the surge for the unvaccinated, the pandemic of the unvaccinated, meaning to say that if you are vaccinated, then less likely you may get the breakthrough infection, but you may not end up in the hospital. And that's a lot of difference, getting into the hospital and spending so much. So I think education and presenting the stark reality that the benefit that you can get out of it. That's otherwise you cannot really force them, because if they cannot actually change their mindset, then boy, it would be difficult to have them change. And that is actually a problem in Sambuanguita, where I used to work for a number of years, like 2 years. I heard from my health workers themselves, who are vaccine hesitant. So what more for those who are actually not health workers and living in the far parishes or far capillas, chapels. So that would be a very, very challenging role for the church, because we are actually spread all over the Philippines, and therefore I think the parish priest has to come in and say good thing, and even something that would actually convince the parishioners to get the vaccine.
Thank you, Father Tex. Any other people in the audience who would like to share their experience on how they were able to convince their lay mission partners to get vaccinated?
I think not only the lay partners, also doc, but of course, the members of the community, the religious, are also very difficult to convince to be vaccinated, actually. No?
Sister
I think-
Malen. Sister Malen, I don't want to put you in the hot seat, but is there some sharings from your experience in your community, how you were able to convince them?
I think from our perspective, because we're a very small group, no, and even in terms of our lay staff, they've been wanting to go home to their provinces for vacation, and they know that there are policies or restrictions as far as their LGUs are concerned, that if they're unvaccinated, they cannot go home. So that has become an incentive. And for our vulnerable sisters, we have made it a policy: no vaccination, no go out. Especially when we
That's
had
good.
all this news about the scare from the different communities, and then they understand. So it's manageable. They're very small.
So no mauling.
No mauling, no mauling. Very strict.
No mauling
protocols.
approved.
Yeah.
No
Now,
vacation.
let me ask you po, did you write that as a written policy that you sent out as a letter addressed to all your members? Is that something that we should be thinking of?
Well, we just had a conversation because we have a designated sister who's the infirmarian, so she's the one who communicates.
So verbal communication. Alam ko sila Father Tex, we met them in groups, no, Father Tex, parang
Yes.
community meetings. But maybe for lay partners also, you can call them in a community meeting, but also you can put out a written memo. Why increase the risk of our community to COVID just because you as a lay volunteer was not vaccinated and eventually, brought the COVID to that community? So maybe because one of the things that works really for vaccination is a prescription from a doctor. But if these are lay volunteers, maybe whoever is in charge of that community can also have a written memo or something. I know that the Vatican now has a very nicely written communication guide. So maybe that can be used, how to communicate and what to communicate. Because we have been communicating a lot about hospitalization, mortality, but maybe there are other data that they need to understand, like cost. How expensive will it be for your family to care for you? And how much opportunity cost will be lost when you are hospitalized and can no longer earn a living? So maybe these are some of the things that need to be communicated that we have not been communicating. In one of because I'm a member of the vaccine panel experts, we have been exchanging experiences. And there was one experience in a community in Cebu about tricycle drivers. No, tricycle driver ba ang tawag doon? Okay. Opo, yun po. So may isang nagmamaneho ng tricycle na nakausap ng doktor sa Cebu na ang sabi, he does not want to get vaccinated because he has no time. He has no time not to make his daily pasada, to line up in a vaccine center and to get the vaccine, because those precious times spent lining up will mean how many pesos of opportunity lost. So they also can think about lost opportunities economically. So if we can make the vaccination more friendly to them, kunyari, we know that the tricycles, they line up, diba? Pila yan eh. If we can talk to the TODA and coordinate a vaccine program where they are lined up, diba? The vaccinators will go there where they are waiting for their pasahero. Get the vaccine as close to them as possible. So, send out an official memo, communicate opportunities lost economically, they will understand that. Bring the vaccine to them. Mag-house to house na siguro. Pwede naman. Kakaawa din nga naman. I can understand, hindi po ba? They are afraid of the opportunity lost if they will miss the number of passengers that they can get while lining up for the vaccine. Okay. Any other people would like to share? You can raise your hand or just unmute yourself because we are a small group anyway.
Okay, so we have question here from Evelina Lagmay. May I read this to you, Doc?
Okay.
Good morning po. Mag 2 years na po itong COVID-19. Although bumababa na po ang new cases dito sa Philippines, may fourth wave ng nagkaka-COVID sa Germany. Nangyayari po ito maski madami na ang nabakunahan doon. Maging cycle lang po ba ito?
Yeah. So this is what we are now experiencing. COVID is becoming endemic. Ano ibig sabihin ng endemic? Nagiging part na yan ng nagsisirculate ng mga viruses sa ating bansa at sa buong mundo. It's just a matter of us learning how to control the complications, including hospitalization and death, no? So ano ba parang endemic na nangyayari? Ang influenza, for example. Nagka-pandemic yan Spanish flu, di ba? Millions really died from the Spanish flu. And then eventually there were many kinds of flu. There are so many kinds of flu viruses that keep on circulating and recirculating and changing in their, di ba? Hindi naman siya mutation, but there are variations. There are antigenic drifts and antigenic shifts that can occur so that every year you experience that there is a different kind of flu vaccine, di ba, every year. Have you experienced that, those of you who get the flu vaccine? So we think that that is what will happen to COVID. It will become, hopefully, less deadly because we are just really buying time. This period is buying time period. Buying time for new vaccines, the best vaccines to be developed. Buying time for safer and more affordable oral medications that we can just take at home, no, so that we no longer get to the hospital with complicated cases. And of course, to continue to learn what infection control is and to continue to practice good infection control. Kasi it was never our habit to wash hands and to wear face masks, diba? It was not our habit to socially distance ourselves. And now it has become an integral part of safety, especially in communities that live together. So unfortunately, yes, it is now becoming endemic. And those places that were highly vaccinated who are now experiencing some kind of outbreak, not as bad, by the way, not as bad. Yung sinasabing fourth wave was never as bad as the first and the Delta wave. Because we are learning as people, as scientists, as communities, no, to cope with and to discover new treatments and ways to manage the impact of this kind of virus. And there will be another pandemic. Gaya nga ng sabi ni Father Tex, we were actually, the Jesuits, we were preparing for SARS 10 years ago. Kaya naman nagkaroon dyan ng infection control na medyo naging strict kami dyan sa infection control practices, including isolation and training of the staff, is because of the SARS. That helped prepare to some extent the way infection control was being communicated there, no? And that is also why Korea, Japan, and Taiwan, and even to some extent China, that were badly hit by SARS, were the most prepared. Remember, at the start of the pandemic, because they already had a system in place to discover drugs or vaccines to manage in big groups, no, the surge that was happening. So hopefully, sister, I answered your question. Sister,
Yes po.
salamat po.
Thank you very much po,
Yes,
Doc.
it will become endemic, unfortunately. That is how pandemics become. That is how it becomes manageable.
So we have the Another questions, but I just want to read this one. So, good morning po. I am Nicole from UST Legazpi, LA Dominican. Due to various demands in many online classes as well as to my other organizations in school, it really does affect my sleeping pattern. How do I make a difference in my sleeping pattern even if my tasks are already piling up left and right? Am I really having a trouble to have 6 to 7 hours of sleep or to manage my time in making my modules, especially when we have a video performance test in a specific subject? Thank you po, and
Yeah,
God bless.
Dr. Pris
Ayan.
Sanchez, that's for you. Dr. Pris, please unmute yourself. Thank you.
Well, from the sound of it, you're young. You're
Yeah,
not
she's
a
still
senior
student.
citizen, you're a student. And I sound like an old fogey saying this, but we've all been through that, right? And maybe earlier on earlier this century, there was less workload. But it's undeniable that now, especially since you are limited to online classes, is that right? Are you limited
Yes.
to online classes? Well, since you're just staying at home, I guess your professors are assuming that you have more time to devote to doing your work without having to commute to school or without having to get dressed and traveling to school and all the rest of the things that used to take more time. But as a student, you do have your responsibilities, and I think it is a matter of time management. Something that I remember that as a student, I had to sacrifice my sleep hours a lot. And I'm sorry that I can't really give you a clear answer about this, except providing structure maybe will enable you to find some way to accomplish everything that you're supposed to do. As long as you remember to make time for things that are important as well, which is making sure that your physical well-being is cared for, which means getting enough sleep, eating your meals on time, and bathing. Bathing, your personal hygiene is also very important. But if it's really too much, if you're feeling overwhelmed, then I suppose the solution is to discuss it with your professors and find out if there's some way for you to extend or else to reschedule, to find a way to add to the value of what you're already doing, maybe without adding additional tasks. So there's always a way, and communication is key. Always communicate with your professors. If they are sympathetic enough, hopefully they will be able to understand what you're going through. Don't keep these things to yourself, because it's one way to develop stress and anxiety. And I didn't mention this earlier during my lecture, but there was a study that was released which was focused on college students, how being lonely, how maladaptive coping strategies were leading to procrastination, meaning they were taking their time to do things. And of course, this would lead to poor academic outcomes. So the key is to focus on making your coping strategies productive, which means communicating, finding ways to achieve what you're supposed to achieve without resorting to the maladaptive practices that they mentioned. And also mitigating yung loneliness ninyo. If you do it, sharing it with your friends, with your professors, with those of you who are in the same boat, will help you also to find a way to achieve these things together. Maybe not too much in isolation, but as a group, if you're able to share with your supervisors and your teachers, I think you'll be able to find a way to do these things without leading to any additional mental health problems or additional stress and loneliness for you.
Thanks for that, Pris.
Okay, thank you very
Thank
much.
you. I think Dr. Pris highlighted something very important. Many of you have schools, no? And I know that many schools are now looking into mental health issues among students. And schools really need to adapt the schedules and the deliverables of our students, because they might be asking too much, no, from students, and it becomes a problem now. And of course, aside from managing the curriculum so that students can adapt to the high pressures of the current situation, schools are now having more counseling, guidance, counseling opportunities for students to communicate with professionals, no, or to talk to someone, maybe their mentor or their, like Doc Pris said, their professor about such pressures that they are experiencing. But sleep hygiene alam ko merong mga text ng text hanggang alas 11:30 ng gabi, text ng text kasi, and nanonood pa ng Netflix hanggang 12 p.m. So,
Totoo.
nakaka-affect yan sa sleep. Okay, yun po. Salamat po.
Yes, I would like also to have a follow-up question with Dr. Pris. Doc, there are a lot of schools who are now applying for face-to-face learning, but then considering that there are many of our students, tama yung sabi ni Dr. Racheli, that many of them slept very late at night, even the following morning at 1 o'clock, 2 o'clock. And then when, of course, when face-to-face learning will be open up for this December and then next year, how are they going to cope that up? No? Paano nila po yung, kasi they are already used to wake up after lunch, they are very active, night, very late night, and then tulog buong araw. Paano po yan? Are they also suffering from depression? How is it, Doc?
It's very possible. As I mentioned in one of my slides, and even that local study, among the populations that are highly affected by mental health issues are women, the youth, and students. So they are very, very prone to depression, certainly. But having said that, though, one of the gifts that's given to young people, to the youth, is resilience and adaptability. Okay, so many of them, most of them, would have adapted very well to online learning. No? Of course, there are a large number also who found it difficult, who became depressed, who could not cope in a productive way. No? Some of them turned to drugs in order to, and down withdrawal, or they just didn't attend their classes anymore. No? So yun yung mga signs of poor coping. But I believe that going back to face-to-face classes is something that many of them look forward to. And they'll be able to adapt physically. They are stronger than us. They are more adaptable to changes in schedule. And I do believe that it might take time for some na bumalik to the usual schedule of waking up at 6 o'clock, 6:30, mag-breakfast, kumain, and then get dressed to go to school, no? But I believe, this is just a speculation, but for a majority, I think it's something that they will look forward to and will willingly adapt to, and will adapt to quickly, particularly yung mga very young kids who have been so trapped at home over the past 1.5 school years. My goodness. My own son is going a little bit nuts already. But I do believe that they are quite adaptable and they will look forward to it.
Okay, thank you so much, Dr. Pris. We have another follow-up questions.
We don't have time anymore po. Sorry, I see a question on how do we gradually open up our schools. I think it's also beyond the scope of this webinar. Yeah. Maybe we can conduct a webinar on schools. Kasi there was a...
For students? Intended for students?
and teachers, di po
Yeah,
ba? I think
pwede.
that would be a good webinar. Maybe
Okay.
AMRSP can also conduct that because many of you have schools. So let's keep that in mind. We can conduct a webinar for you on that, on these issues, no? Thank you po.
So thank you so much po for all our member congregations who are here, and for those questions who have been sharing with us. Thank you so much po for participating. And of course, I think Father Dan is here. He has been with us since the start po. So it's almost time, and this is the only webinar that we entertain questions for enough time, because we were never did it last time. Am I right, Doc? Last time we are overtime na po kaya bumawi tayo.
Maganda kasi ang mga topics and exchange of
Yeah,
opinions po
That's it. Okay, so may we give the time for Father Dan Vicente Cancino, Jr., MI, the current Executive Secretary and Director of the CBCP Episcopal Commission on Healthcare, for his closing remark. Father Dan. Okay.
Hello, magandang umaga po sa ating lahat. God bless all of us in this very fruitful webinar. I was listening to Father Tex, to Dr. Shelley, and Dr. Priscilla. I remembered also my parents. My mother is 97. My father is 90 years old. And they had COVID. Nagka-COVID po sila. But they are now vaccinated. I remember them with your stories, with the different things that you were asking. But I remember them as I give to you these closing remarks. Even at the darkest moments, as in these months of pandemic, I think the Lord continuously to send us angels to console us in our loneliness and remind us that I am with you always. And we have here 3, 4, 5 angels sent to us to remind us that God is with us always. Thanks to Angel Father Tex, to Angel Doc Shelley, to Angel Doc Priscilla, to Angel AMRSP, to our Angel Sister Clofe and Sister Malen, and to all those who are taking care of our elderly. You are truly the message of the Lord when He says, I am with you always. He says this to you and He says this to us. And this is a good webinar where the church is very concrete in telling us that truly God is with us always. And I hope that this preparedness, our preparedness to respond to mental health issues among the elderly in this time of pandemic, is really a response out of love and out of that impelling love of Christ to those who are sick and to the elderly. Alam nyo, ang mga elderly natin ay they are signs of true presence in history. Sa kanilang mga muka, kahit ang dami na po yung mga lines, tama po ba? Mga wrinkles. But these wrinkles are strokes. Strokes of sacrifice. Strokes of love for all of us that can be handed down from one generation to the next. And with our angels here sharing their life, not only your expertise po, but I felt you have shared your life to us because you have been serving the elderly, you have been serving the sick, and what you have shared is your life. Maraming salamat po sa inyong lahat. And to AMRSP, in collaboration with the Institute of Aging of UPNIH, together with the Episcopal Commission on Healthcare, sa ngalan po ng mga obispo, maraming salamat po. Hindi po natatapos dito ang ating webinar. Ang totoong mission po natin ay hindi dito sa webinar. The true mission continues after this webinar. And I hope all the knowledge, all what they have imparted to us, nurtured our mind, but it has also nurtured our heart. So that in our hands, full of love, we can reveal to them who our God is. Thank you so much. May God bless you and keep you always. Thank you, sister.
Okay, thank you very much, Angel, Father Dan. So we are all angels in one way or another to our community and to the society or in the field of works where we are now. So may we continue to do the mission God has entrusted to us. And of course, to our medical teams, Dr. Shelley, from the very beginning of our webinar, we are very grateful to all of them. Okay, so as what Father Dan have said, this is not the end of our mission. This webinar continues. This webinar ends, but our mission continues. Yes po, Doc Shelley.
Opo. Thank you very, very much po. Mukhang
Ayan.
hindi tayo matatapos pala, sister. Meron pang mga requests for
Kaya
schools,
nga.
students, teachers, guardians. So
Marami.
we will help you po. We have a lot of resources that we can gather together. And I thank you very much, Sister Clofe, Father Dan, for your support. Of course, our text
Yes.
team in AMRSP, Father Toots. Wala siya ngayon.
Wala
but
siya,
very
oo.
active here.
It is really a good collaboration, a tripartite
Opo.
program of the National
Yes.
Institute of Health and the CBCP and the AMRSP.
Opo.
Talagang
Salamat
napakalakas po na ano po to. Okay, so maano po natin, we still have the time for our sisters to encourage them to get vaccinated because there will be a bayanihan, bakunahan po ng ating government.
Mhm.
And of course, we sent already letters with the approval po of our co-chairpersons, Sister Malen and Father Shelo, for our members of the congregations to cooperate and collaborate with their LGUs po for the promotions and for the campaign of this upcoming event po ng ating vaccination campaign.
Thank you.
That is for the last week, November 29 to December 1, I think. Okay? So thank you so
po.
much to
Thank
our
you.
dear sisters and brothers who join us for today's webinar and for the future po na mga webinars po natin. So, Doc Shelley, looking forward for another
Another set, yes.
And
Thank you
Father
po.
Dan, no? Looking forward po for another core meeting in the future for the common good po ng ating mga...
You're assured po. We will
Salamat
continue
po.
this. We will
Salamat.
continue this.
Salamat
Yes
po.
po,
Thank you.
Father. Thank you so much.
Take care.
So, we will not say goodbye because we will see you again in the future webinars. So, we very grateful po sa lahat po na nandito ngayon. Father Dan, could we request po for the final blessing for our, Sorry, si Father Dan.
Wala na ba si Father Dan?
Kalimutan
Baka Father Tex.
Si
Sorry
Father
na.
Tex to
Father
give us
Tex,
the blessing
final
po
blessing.
before we...
Blessing.
Mm-mm.
Blessing po.
Sige, it has been a very wonderful morning, huh? And I
Yes,
think
Father.
a lot has been said and very, very crucial to how we manage this pandemic in many aspects. May Almighty God bless you all, the Father and the Son and the Holy Spirit. Amen.
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 Go
Amen.
on and be peace to every one of us.
Thank
po.
you very much, Father Tex.
Thank
Thank
you.
you po. Okay.
See.
Okay.
Bye-bye.
Take care, Sister Cleofe.
Yes po, Doc. Ikaw
Okay,
din. Thank you
text,
so
text.
much. Text
Email,
lang po
email.
tayo. Sa mga sisters pa natin, nandito po, dahan-dahan na po sila nawawala.
Opo. Yung ating
Bye po. Ay,
certificates
hindi
po.
pala.
Certificates.
Yes.
May utang tayo. Salamat po. Over and out. Thank you.
Okay.